What is going on, guys? This is Dr. Ryan Garner with Apothicor Wellness. Today's video is part of a series in which we do a deep dive analysis into a patient case. This is beneficial for our current and future clients, as well as other healthcare providers, just to get some insight to our approach to maximize patient outcomes, utilizing the most up-to-date evidence and the lowest cost drug regimens possible. So our patient today is MK, a 56-year-old male. He is 70 inches tall, so about 5'10", weighs 167 pounds and has a BMI of 24. His 10-year ASCVD risk, which is our cardiovascular risk, is about 10.4%, and he only has a history of type 2 diabetes. His medication list includes Zigduo, which is a combination of dapagliflozin and metformin at a 5-1000 milligram dose, extended release, 2 tablets every morning. Glipizide 5 milligrams, extended release, 1 every morning, and atorvastatin 10 milligrams, 1 daily. Now, the first thing we notice is that our patient has a history of type 2 diabetes, but what we would consider a pretty normal BMI is what we would generally consider metabolically obese with a normal weight. What this means is that this patient has a normal BMI. However, BMIs can't tell us the whole story. They are a useful tool, but it must be in combination with patient lab values or physical appearance to really tell the whole picture. So what's going on is this patient is likely actually holding a lot of that adipose tissue or fat tissue in the abdominal region, and that's translating into visceral fat, which is fat that surrounds our organs, and this is our primary driver of insulin resistance in diabetes. Patient's A1C is looks like it's pretty much at goal. So the first thing we're going to look at is what medications are on board that we don't need to have. The first thing we're going to look at is the Zigduo. It is relatively expensive. Patient does not have a history of cardiovascular disease, does not have a history of reduced or preserved heart failure, doesn't show any signs of symptoms otherwise. We know that from the Declare TIMI, DAPA-HF, and the DAPA-CKD trials that this patient actually gets no additional benefit beyond blood glucose lowering from this medication as regards to outcomes. Now, I'm not a big fan when it comes to using sulfonylureas like glipizide. The reason being is that it's kind of just a Band-Aid in a way that we can reduce blood sugar, but we're really not overcoming insulin resistance. We're essentially telling our pancreas to release more insulin so we can shove more glucose into our cells. So ideally, we'd like to either discontinue this or we would like to reduce that dose. Now, when we look at the comparison between sulfonylureas and a drug like pioglitazone, we can see that sulfonylureas actually don't mobilize that visceral fat the way that something like metformin and pioglitazone can. Which obviously is one of our goals if we want to overcome that insulin resistance. Now, pioglitazone doesn't get used all that often. It's a drug that I really, really like, but it does have its caveats. And these are the reasons why providers oftentimes shy away from using it. There are associations with some fluid retention, with complications with heart failure, complications with bladder cancer, and certainly a fracture risk. Fracture risk is in my opinion, the most important thing to consider in an older age demographic. We got most of this data from the IRIS study that did show an increased risk of fracture. The average age of this patient was about 63 years old, but we did find an increased fracture risk emerge after about 2 years. Other meta-analysis on this medication and fracture risk have shown about a 1-year emergence of this risk. The one thing we have to consider is that in the IRIS study, they were also just recently released from the hospital from a stroke or a TIA, which certainly increases that fall risk, which is where most of these fractures occurred. Simultaneously, metformin may be protective of bone mineral density, so it's very important that is something that we have on board to potentially counter that reduction of bone mineral density. So patient is currently on atorvastatin 10 milligram, and that is great. Diabetic patients are at an increased risk of cardiovascular disease. A study from Monier in the UK established a greater than 2-fold increased risk for cardiovascular disease in diabetic patients. So we know that statins on board with type 2 diabetics is really important. but do we need to make any changes to the current dose? When we look at the multitude of data, such as the Ascot LLA study that looked at type 2 diabetics using atorvastatin 10 milligrams or not, we saw a 23% reduction in the atorvastatin group as far as their cardiovascular risk, with a decrease in about 35 milligrams per deciliter of LDL. We know that in the TST, or Treat Stroke to Target study, we had much better outcomes for LDL below 70 compared to the group that was between 90 and 110. And meta-analysis that have looked at the reductions in LDL and cardiovascular risk generally show a decrease in cardiovascular risk as LDL goes down. That risk does taper a bit, but it is very well established. Because this patient has a cardiovascular risk, a 10-year cardiovascular risk over 10.4%, we would ideally like to reduce that LDL as much as possible. Currently on a 10 milligram dose, which is great, but patient could likely benefit from increasing that dose to a higher intensity to decrease the LDL as much as possible, as long as the medication is tolerated. So what's the plan going forward? So we're going to discontinue the Zik Duo. As we mentioned, the patient does not have any need for the dapagliflozin because they won't have any greater outcomes with it on board other than reduction in blood glucose. We're going to initiate a metformin extended release 500 milligrams, doing either 4 every morning or split doses. The glipizide extended release, we want to decrease to a 2.5 milligram dose, just so we are minimizing how much weight gain from it, but we're still getting some benefit, with the intent of discontinuing this medication dependent on any kind of lifestyle changes and their impact on A1C. We're going to initiate pioglitazone 15 milligrams daily, monitoring for any kind of fluid retention, weight gain, and monitoring bone mineral density. And we'll titrate this to our target A1C. It does take some time to start working, usually in the 2 to 3 month range, with a goal to discontinue the pioglitazone after 2 years once we've mobilized more of that visceral fat into subcutaneous fat. We're also going to start a vitamin D and calcium supplement at 1,000 milligrams calcium, 600 milligrams of vitamin D. This is just the FDA recommended daily allowance. And this is just going to help supplement any kind of bone mineral density loss that we might have over this 2 years of the patient's on the pioglitazone. We're going to increase the patient's atorvastatin dose to 40 milligrams to a higher intensity. Patient tolerated the lower dose, so we have no reason to believe that a higher dose wouldn't be tolerated. Just because this patient is at a normal BMI does not mean that they can't benefit when it comes to lifestyle changes. We're going to initiate a calorie restriction of around 1,916 calories per day. This is generally the level of what we'd expect a patient to burn through from their BMR, as well as from digesting food. And by reducing calorie intake, this is also a way that we are going to reduce subcutaneous and visceral fat simultaneously, helping to further reduce insulin resistance. And we're likewise going to have a patient target around 60 grams of protein a day. Again, this is just per the FDA's RDA. And of course, lifestyle changes would be complete without increasing exercise, with some emphasis on resistance training. So let's go ahead and look at the total costs. For the metformin, we can expect about $128 per year. For the pioglitazone, we can expect about $144 per year. We expect very little change as far as the cost of the glipizide and the atorvastatin. We see a pretty negligible change in cost when changing doses. We're also going to see about $120 a year for the calcium and vitamin D supplement. So what do the savings look like? The savings would be on the discontinuation of the Zik Duo. Now, there is a difference between the pre and post rebates. Rebates are a big factor when it comes to pharmacy benefits, and we have to absolutely factor them in. Now, the problem is that rebates can vary very much depending on who is negotiating those rebates for you, depending on how much the PBM is retaining, depending on the drug that we're using. Some drugs that have a very competitive space will offer higher rebates, such as the GLP-1s, and other drugs that have fewer competitors in their space will obviously offer lower rebates. Looking at about $6,750 as far as the pre-rebate savings on the Zik Duo. Post-rebate number looks a little bit more like $4,250. So what's our difference in savings? We're looking at a difference in savings of about $6,350 pre-rebate and about $3,860 post-rebate. Patient is still on track for the same outcomes as before, but we are hopefully able to reduce some of the drugs that have less desirable side effects and help to overcome this insulin resistance. I appreciate you guys tuning in. Don't forget to like and subscribe and follow our channel on LinkedIn. Take care.